Scaphoid fracture. This is the scaphoid bone which attaches proximally to the radius and distally to the different carpal bones. It is the most commonly fractured wrist bone, and it most commonly fractured by the fall on outstretched hand. This is the scaphoid bone which is having fracture in the middle part. In almost 10% of the individuals, it is supplied solely by the radial artery, which enters through the distal portion of the bone. Here the blood supply of the scaphoid is shown. It is supplied by the radial artery, branches of the radial artery, and which enters the bone distally, and it moves towards the proximal part. Here the blood supply to the scaphoid bone enters distally and supplies the scaphoid in the retrograde fashion. And if there is a fracture in the waist of the scaphoid bone, the middle part of the scaphoid bone, then the supply to the proximal part becomes compromised, and avascular necrosis of the proximal part of the scaphoid bone occurs. In this radiograph, an oblique fracture of the scaphoid bone is shown. Here it is highlighted. The fracture is easily missed as it causes little pain and swelling, and it is often not so clear on the radiographs. And the fracture can be displaced and undisplaced, and undisplaced fracture is often not clearly visible on the radiographs. And the main presentation is tenderness in the anatomical snuff box. Here anatomical snuff box is present in the picture. The base of the it is the triangular depression formed on the posterolateral side of the wrist, and base is formed at the wrist joint, and apex is on the thumb, and lateral border is formed by the tendons of the abductor pollicis longus and extensor pollicis brevis, and the medial side is formed by the tendon of the extensor pollicis longus, and its base floor is formed by the scaphoid and trapezium, and radial artery runs through it obliquely. It is an important clinical region. When the hand is in the ulnar deviation and thumb is extended, it becomes visible, and the scaphoid bone becomes palpable in the anatomical snuff box. This position enables the physicians to palpate the bone to assess for the fracture, and radial artery pulse is also felt in this region. If patient presents with the tenderness in the anatomical snuff box after fall on the outstretched hand, then special scaphoid view radiographs are ordered. And if fracture is not evident on the initial radiographs and tenderness persists in the anatomical snuff box, then suspected scaphoid fracture is considered. In this case, immobilize the wrist and examine again 10 to 15 days later. If the tenderness remains, then repeat scaphoid views. If facilities and resources allows, then isotope bone scan, CT scan, and MRI can diagnose the fracture earlier. If there is evident fractured scaphoid bone on the radiographs, then if it is undisplaced, then the conservative management is done non-operatively, and the plaster immobilization of the wrist joint is done. And if there is displaced, unstable, and proximal pole fracture having avascular necrosis of the scaphoid bone, then treatment is done by the open reduction, rigid fixation with the headless compression screws. In this picture, fixation of the scaphoid bone is shown.